lecture. Today, I think one of the most important one today, and the, the second one is by Dr. Vivek. And today we are just going to start the first lecture on after AKI on renal replacement therapies. The basic principles will be discussed by Dr. Vivek. And he is a very renowned intensivist, a cardiac anesthetist, and he's working in Dayanand Hospital, the Dayanand Medical College. This is also a medical college, and he is basically the coordinator of the ECMO program and in the DMC Heart Institute. He has he is doing a lot of ECMOs in patients, saving patients of sulfos poisoning. Aluminum phosphide poisoning is very common in the rural areas of India, and it has a very high mortality. And I have not seen any center in India other than Dr. Vivek's who is saving these patients randomly. And he has an excellent success in this. And I don't have to say much. You will hear from him and you'll understand how experienced he is in renal replacement therapies. So, to you, Dr. Vivek.
Thank you, sir. Thanks for the kind introduction. Good evening, everybody. And I'm thankful to Dr. Saab for giving me opportunity on this forum to speak on the renal issues. And once a patient in the intensive care unit has developed the acute kidney injury, he is not responding to the supportive therapy and conventional management, and he's worsening. So this is the time to think for renal replacement therapy. And this is what I'm going to talk, that what is the basic principle. My talk will also include about the vascular access, use of anticoagulation, and what are the different principles and what are the different options we have in the intensive care unit for managing these patients. So just quickly recap that how the nephron, the basic unit works. It's a nephron. So the blood is coming through the renal artery, and through the afferent arteriole, it is reaching to the Bowman's capsule, and there is a filtration taking place, and ultimately the blood is returning back with the efferent arterioles, and this, because of these pressure changes, ultimately the filtration is taking place, and at a different level of the proximal tubules, loop of Henle and distal tubule, there is again the reabsorption of the fluid and exchange of the some solute. So this is the basic concept about the kidney we all know. But just to compare this with what these renal replacement therapies do. So if we talk about the renal artery, it is in the any of kind of a renal replacement therapy, it is like an access line that we are taking the blood. Renal vein, it means it's a return line, that what blood is going back from the kidney after the filtration and everything. So this is the return line. And the kidney, what is the function of the kidney? It is being replaced by the filter, our hemofilter, what we call it as. Then the filtrate line is basically a ureter, and the drainage bag is like the urinary bladder where we collect, where the urine is collected. So if we talk about the various therapies options which are available in the intensive care unit, it can be divided into the intermittent, what we commonly called as intermittent hemodialysis, or sometimes isolated ultrafiltration for a very short time. And the other extreme is the continuous therapy in the form of CVVH, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, continuous veno-venous hemodiafiltration, or slow continuous ultrafiltration. So when we say continuous, the therapy is exceeding beyond 24 hours, or even it is going for several days. And between these two comes the hybrid therapies, which are not for such a shorter duration. They remain for 6, 7, or 8, or 10 hours. And this is what we call as SLED, that sustained or slow low efficiency dialysis, or we add one more D for the daily dialysis. We do every day for 6 hours, 7 hours. Similarly, because this is only a dialysis, so if we add the filtration with this, we call it as SLED F. That means we have added the filtration to this. So all have its own advantage as well as disadvantage. Continuous the renal replacement therapy has a special role in the intensive care unit, because we all know that we come across with a patient who is hemodynamically unstable. We are struggling to maintain the hemodynamics with the vasoprotective substances, the inotropic support. So many times in ICU, we are coming with the cardiac dysfunction, cardiorenal syndrome. So we are coming across with the multiple problems. And in that, if we only try the intermittent hemodialysis, then possibly it will not be a good choice. And even the CADICO guidelines say that the continuous therapy should be initiated in those patients who are hemodynamically unstable and which are most commonly we come across in the intensive care unit. So what exactly is the CRRT? It is basically a blood purification technique which is for the impaired renal function, which we are applying for more than 24 hours. Means on the daily basis we are continuing it, and it can go for the days or even sometime 4, 5, 6 days or 7 days, depending upon the how the renal recovery is taking place. So we all know why I am comparing this. We should be aware that what we are actually achieving with any kind of a renal replacement therapy. So the common kidney has several functions like maintaining fluid balance, electrolyte balances, maintaining the body homeostasis with the acid-base balance, and excretion of all the metabolic byproducts like nitrogen, urea, creatine, or even some medications. And these components are also actually supported by the artificial kidney, means by any kinds of a renal replacement therapy. But we must remember that there are certain functions of the kidney, like synthetic functions, are regulation of the blood pressure with the renin-angiotensin aldosterone mechanism, or calcium phosphorus balance, which is hormonal functions. These are not supported by the kidney, and we should always understand. Moreover, the another big difference that the amount of filtration which can happen with the normal kidney, which is not possible with the help of artificial kidney. Moreover, the kidney has a unique function that the reabsorption of the fluid as well as the reabsorption of certain solute is possible with the kidney, which actually we cannot achieve with the renal replacement therapy, any kind of a renal replacement therapy. So what all we need when we want to do to support our patient, the renal support, what we need. So we need an access because we have to take out the blood, and after filtration we have to return it back. So we need a access with a double lumen catheter, hemodialysis catheter. Then we need a circuit because blood has to pass through this, and there should be a artificial kidney or hemofilter. Then there should be some pump, certain pumps, at least for blood, one pump and one pump for controlling the effluent. And if we want to add in our therapies, like we are adding a dialysis therapy, then there should be a dialysate pump. And if we are adding a replacement, that's a hemofiltration, that means we need another pump to run these solutions so that we can control all the component of the therapy. So once the blood is taken, passes through the circuit, passes through the filter, filtration takes place, whatever therapy we have selected, and ultimately it is being returned back to the venous line, blue line. So if we do a cross section of these basic filter, so we'll see a hole of fibers in which inside there is a blood and outside there is a dialysate. So you can see in this diagram, dialysate is entering from one side and blood is passing inside this, blood is coming inside these hollow fibers. And now after, because this moves in the counter current direction, you can see that dialysate is moving in this direction and blood is moving in this direction. So they are in the opposite direction. And ultimately the effluent which comes depends upon what is there high in the high concentration the dialysate and what is in the high concentration the blood. It will take exchange and it will move on the either side. So these are basically a semi-permeable membrane, and water can easily move through this membrane, but certain solute can pass and certain solute cannot pass. There are two types of membranes, cellulose and synthetic membranes. Synthetic are usually used in the CRRT, and these are different kinds. You can see AN69 membrane and other membranes, and these filters can be continued till the time they are clotted, clogged, or contaminated. They need replacement. So we have already discussed that the artificial kidney had the limitation of the blood flow, do not have a synthetic functions, and calcium phosphorus balance is not regulated. So how what are the importance of the access catheter? This is probably the most important step when we think of any kind of a renal replacement therapy, and especially for the continuous renal replacement therapy. So the flow, we all know that the flow depends upon the radius power 4 and inversely proportional to the length. So the catheter should not be too long and there should be sufficient radius to achieve a good amount of flow. Moreover, this catheter should not be too hard, but simultaneously it should not be kinkable, because after some time, if it starts kinking, it will um, obstruct the flow. And once there is a obstruction, it will indirectly affect the filter and reduce the filter life. So usually we, for a femoral vein, we need a little bit longer catheter, 20 to 24 centimeters. For internal jugular, 16 centimeters. Usually these are the accesses we go for first. Femoral because it's a straight access, internal jugular because less chances of infection, and but we avoid the subclavian vein because of certain reasons. One reason is in the long term, if the catheter is in place, it can lead to a subclavian vein stenosis. And moreover, if there is an arterial puncture or there is some injury to the vascular system, controlling bleeding will be a bit difficult in this situation. Whenever you are choosing a site, you should remember that if there is a high abdominal pressure, it is going to affect the femoral flow. And if the patient is on ventilator and he's fighting with the ventilator, that is going to affect if your cannula is placed in the internal jugular vein. You can see in this study that the filter life actually gradually blood flow decreases, and this decrease of the blood flow lead to stasis, and ultimately this reduces the filter life. So you have to be very careful about the access. So these are the catheters. You can see that the jugular, we can have this kind of a kink catheter. A straight catheter can be placed in the femoral vein or even in the, if needed, in subclavian vein, which is not recommended. So the technique is always a percutaneous one. We are well aware of the Seldinger's technique, how we place. The important thing, whether it's a rounded or it's a D-shaped dual catheter, if the size is above 11 French, then you can achieve adequate flow in the CRRT. So these are the different connections with the catheters. So coming on the principle of CRRT, which is very, very important, that how this works. So the diffusion, we are well aware that diffusion is a technique which is used in the all kinds of dialysis. The other one is the convection, ultrafiltration, which is talking about only the fluid removal, and adsorption, where there are certain molecules get adsorbed on the surface of these membranes, and they can play a vital role in the management of the patient. So taking one by one, this diffusion, basically movement of the solid through a semi-permeable membrane from a higher concentration to the lower concentration. And with this, we can remove the small molecule. A small molecule can be removed like a urea, potassium, these all can be removed. And basically, when there is a semi-permeable membrane, on one side there is a blood and on other side there is a dialyzed solution. So this small molecule can go with a concentration gradient, that higher concentration on the side will try to equilibrate on the lower concentration on the other side. So either way, these movement can take place. And this transport mechanism in the CRRT is used in the CVVHD and CVVHD. But remember, it is useful for the smaller molecules only. The other mechanism is convection, which is used unique and used in the CRRT. It is basically a solvent drag that through the semi-permeable membrane, water is being transferred, and along with the water, because of the hydrostatic pressure in the blood, there is a movement of the molecule. And remember, in this, this is the middle molecule which is passing through this. And along with the middle molecule, naturally, the smaller molecule can also will also move. So it depends on the how much water is being taken off. And this transport mechanism is used in the CVVH therapies and CVVH-DF. Then third is the ultrafiltration, means it's a removal of fluid, and along with the fluid, because there is a positive pressure generated on the blood side, so a good amount of fluid can be taken out with the help of a fluid pump. This can be taken out, and the pressure difference between these two areas, like on the blood side and on the other side, that's called as transmembrane pressure, and this method is used in all therapies because we want to, along with the solute, we are taking out the fluid. So scuff, CVVH, CVVHD, and CVVHDF, in all these categories, we use the ultrafiltration. Some amount of solute do move along with the water, but usually solutes are not removed in this. And the fourth mechanism is the adsorption. It is basically the solutes are adhering to the biological matter or membranes, and it all depends on the what type of membrane is there. But it has some limited value because after some time, when there is a equilibrium state, then probably it may not be very useful. And this has been shown that in the sepsis patient, probably those inflammatory mediators, they adsorb to the surface and gives some initial improvement in these patients. So what the different sorry. So what the different modalities are depending upon this mechanism: SCUF, slow continuous ultrafiltration; CVVH, continuous veno-venous hemodialysis; CVVHD, continuous veno-venous hemodialysis; and CVVHDF, continuous veno-venous hemodiafiltration. So what is SCUF? So ultrafiltration basically purely removes the fluid from the body, and therefore it is for the management of those fluid overload which are refractory to the diuretic therapy. Here we just require two pumps, one blood pump and other is the effluent pump. We don't require any dialysate or replacement solution, and we can go up depending upon the hemodynamics of the patient. We can take even 2 liters per hour of the fluid removal, but usually we start with the lower one so that hemodynamics is not compromised. Here, one thing is very, very important to remember is the filtration fraction, because this will affect the filter life. What is filtration fraction? It's a fraction of the plasma water which is being actually removed by the ultrafiltration. And what it does, when we take out the water, there is some dehydration of the blood. And this dehydration will induce the clotting of the filter and reduce the filter life. So for calculating it, we know that what's the ultrafiltration that we have kept into 100 divided by the blood flow rate. How much is the blood flow rate? It means plasma flow rate. So 1 minus hematocrit, blood flow rate into 1 minus hematocrit will give you a plasma rate. So for preventing a clotting, your filtration fraction should be less than 25. And if this can also be achieved, higher blood flow rate, and we maintain a pre and post dilution. So in those, we can reduce this, and we can we will be able to achieve a good filter life. Filtration fraction, basically in the all advanced machine, you will see the percentage of filtration fraction of the machine itself when you do a prescription, and you can adjust those prescriptions accordingly. The other is continuous veno-venous hemofiltration. Basically, as I said, it's a hydrostatic pressure gradient across the membrane from the blood side. So there is a solvent drag. It requires, again, the blood pump, effluent pump, as well as the replacement pump. And here we need a replacement fluid. But please do not get confused that this is the replacement of the fluid. We are adding the fluid, and ultimately it is the ultrafiltration what we are targeting. So accordingly, we adjust at the final. This is not the replacement of anything. We are adding some fluid so that the good amount of hemofiltration can be done, and we can take out the these fluids. So it is not a replacement fluid per se. We can say it also a substitute fluid. And net filtration depends upon how much filtration we are doing, what effluent we have adjusted. So this can be placed at several places. If you look at this, it can be placed even at the pre-blood pump position. We can have this, or we can have the replacement pump at the before the filter. So this is the pre-dilution, and we can have a replacement fluid after this also, or even before the return when we are returning. So all these are post filter. So we call it as pre-dilution and post dilution. So what are the benefits of the pre-dilution? When we dilute, do a pre-dilution here, because the blood is getting diluted, so solid clearance will be compromised, but the filter life will definitely increase because you are diluting the blood. And if we are doing a post dilution, here we are replacing this after the filter. So the high concentrated blood is actually passing through the filter. So more chances of filter clotting, early filter clotting, but the solid removal will be much better as compared to the pre-dilution. So it is always preferable if you have opportunity in your machine, you just divide your pre and post dilution 1/3 and 2/3 so that you can achieve both. So continuous veno-venous hemodialysis, CVVHD, basically it is nothing but the what dialysis we do with the intermittent hemodialysis are SLED. Here it is the diffusion, basically a diffusion which is taking place, and it requires blood, effluent, and dialysate pump. And we need a dialysate solution. Here we are taking out the small size of the volume, and depending upon you can keep the dialysate flow rate and blood flow rate. Usually we keep from 100 to 250 ml, usually 100 to 150 ml. CVVSDF, it is a combination of both dialysis as well as hemofiltration. So continuous veno-venous hemodiafiltration. Here we need core pump because we have to give replacement fluid, dialysate fluid, and we have to have a blood pump along with the filtrate. So it helps in taking out all kind of a molecule, small and middle, higher size of the molecule. So now what fluid? Because again, it is a very important that we have to have a replacement solution and dialysate solution. So dialysate, basically, it should reflect the normal plasma value to achieve an adequate homeostasis. And it basically, through the diffusion, it is correcting the metabolic problem. So whatever you want to improve in the blood, you keep the increase in the blood, you give it a higher concentration in the dialysate, and whatever you want to take out, you keep in the lower concentration. So if your patient is having a hyperkalemia, so you use the low potassium solution in the dialysate. You want to improve the bicarbonate, so you use the high bicarbonate solution. This is how you correct these electrolytes or buffering agents using the dialysate solution. Replacement solution, because it is coming directly into the blood, where the dialysate solution do not come directly in the contact of the blood. It is separated by the semi-permeable membrane. Replacement solution has to be sterile because it is coming to the direct contact of the blood. It is administered directly into the blood, and it should have the physiological concentration of the electrolyte. Buffer, it has to have buffer. It can be acetate, lactate, and or bicarbonate. Usually lactate buffers are pretty stable, though there is always a concern in patients who are having a hepatic injury where the lactate clearance is compromised. So bicarbonate solution, based solution, replacement solution can be used. The only thing with the bicarbonate based solution, it has to be prepared immediately. Otherwise, it will disintegrate. So these are the lactate based solution. Basically, if the liver function is fine, you can use any solution. It will not lead to any kind of a problem. But you should remember that these are the non-physiological solution because they have the pH of 5.4 and they cause the peripheral vasodilatation. So hemodynamic, if patient is already hemodynamically compromised, then this is possible that the lactate-based solution can lead to hemodynamic instability. And if the patient is hypoxemic, having a liver impairment, there the acidosis may worsen. So that has to be kept in mind. The bicarbonate-based solution, they basically replace the bicarbonate. The concentration 30 to 35 milliequivalent per liter corrects the acidosis in the coming next 24 to 48 hours of the CRRT, and they achieve a better hemodynamic stability, and it is preferred, especially in cases of liver dysfunction. So basically the clearance, CRRT clearance of the solute basically depends on the what size of the molecule. So if whether it's a small, medium or large molecule, and moreover it depends upon the what is the pore size of the semi-permeable membrane or what is the sieving coefficient. Higher the ultrafiltration rate, there will be a better solute clearance. So sieving coefficient, this is an important thing to understand. Basically, it is the ability of any substance to pass through a membrane from the blood compartment to the filter site or to the fluid compartment. So if the sieving coefficient is 1 for any particular electrolyte or for any solute, it means there is a free passage. But if the sieving coefficient is 0, it means this substance will not pass through the membrane. If it is lying in between, so there will be chances that it can pass depending upon the what size of the membrane is there, so it will pass through the membrane. So these are the different these are the small molecules which can be filtered with the diffusion therapy. These are the middle molecules which can be go through the convective therapies, And these are the large molecule. Usually, these are non-filtrable. So once we have initiated the planning for the therapy, the anticoagulation should also be planned accordingly, because we need to prevent any clotting in the circuit so that we can preserve the filter performance and we optimize the circuit survival and we can increase the duration of therapy. Otherwise, after every 15, 12, 15 hours or 18 hours, you need to change the circuit and you have to interrupt your therapy. So that will lead to a blood loss as well as it will add on to the cost of therapy. So any ideal agent, which should be, we can think of, it should prevent filter clotting without inducing any hemorrhage, should have a short half-life, and action should be limited only to the extracorporeal therapy, should be monitored easily, should be having any no systemic effect, side effects, and there should have been an antagonist for it. In case of any emergency, we can quickly reverse it. But unfortunately, so far, we do not have any ideal anticoagulant which can be used. So options, what we have, you may sometime in certain situation you don't administer any anticoagulation. So no anticoagulation, but definitely filter life will be much lower. Systemic anticoagulation using heparin or low molecular weight of heparin. Regional anticoagulation in the form of heparin protamine complex, citrate, and certain prostacyclines. So unfractionated heparin is the most commonly used across the world. Basically, it's inhibits the antithrombin 3 activity. You should maintain the APTT 1.5 to 2 times of the value to achieve an adequate anticoagulation. The advantage, we have a very large experience. It's a short half-life. It has availability of a reversal is very easily can be done using the protamine. It's widely available and monitoring is not very complex. But the issue is, the effect is very unpredictable. There is always a risk of heparin resistance and moreover the heparin-induced thrombocytopenia. So low molecular weight heparin, again, it is another option which can replace, which has been used in the different other indications, and it has been tried in the CRRT as well, because it has a more predicted response and pharmacokinetics and anticoagulant response, and there is a renal metabolism to it, except for the paradox. So its a half-life is increased, especially in the acute kidney injury. The advantage, again, it's available, simple administration. You can do it the weight-based dosing and low risk of heparin-induced thrombocytopenia. But again, it's expensive and you need to monitor factor 10A, and it has a longer half-life. And if you want to reverse it, you can't, because you don't have any drug to reverse the action of a low molecular weight of heparin. Regional heparinization has been tried with the heparin and protamine complex, but it is not a very successful, and in fact, it was associated with certain complications. Regional citrate has come up as a very good option for the anticoagulation, because sodium citrate, which is administered, it makes a complex with the ionized calcium, and once it passes through the circuit, the part has been already goes through the effluent, and remaining is metabolized into the body. And whatever is being metabolized in the body will produce the bicarbonate and will lead to correction of metabolic acidosis. And we can administer calcium so that we do not come across with the hypocalcemia. So, but what is important for it is it requires a strict protocol, that how much infusion of the citrate and how when the calcium, where the calcium has to be done, what should be the composition of dialysate and replacement solution, and a strict monitoring is very much required. Basic purpose of the regional citrate, that it maintains the circuit ionized calcium level 0.8 to 1.6 milligram per deciliter. So basically, once the blood is taken from the body, so citrate is added to the access line. So calcium citrate complex are formed, and ionized calcium in the circuit has been decreased, so that preventing the circuit clotting. Now, a significant amount of the calcium citrate complex are lost with the effluent bath. So you are not worried much. Dialysate solution, again, you have to remember that if you are using it, it should be calcium free. And then post-filter solution means if you are doing a post-dilution, you can add some calcium containing solution. And in fact, before returning this back to the patient, the blood, there should be this will be converted in the liver with the bicarbonate and calcium, and the calcium has to be replenished with a separate IV line to the patients to maintain the calcium level in the blood. So this is how it It is arterial line. You are adding a citrate solution. You are targeting the circuit calcium target 0.3 to zero point 0.5 millimole per liter, and you are dosing a citrate around 3 to 4 millimole per liter, and it is most of them are filtering in the effluent, and you are replacing the calcium gluconate or calcium chloride. You should remember that you have the calcium available calcium in the calcium gluconate is one third of the calcium chloride. So you adjust and then you return it the blood back to the patient so that there is no hypocalcemia. So advantage, it's a strictly a regional anticoagulation, shorter half-life, and it decreases the bleeding risk and even can be used in the trauma patient. But you have to be very, very careful about the metabolic complications. Alkalosis and acidosis both can happen if your dosing is not adequate with the citrate. So technically it is complex. Additional tests are required, so it becomes very costly affair. And in hepatic failure and poor tissue perfusion, definitely you should be very careful for using it. So these are the complications I have already discussed. Other are the prostacyclines, and herodine has also been tried, but not much in cases of CRRT. No anticoagulation again. There are certain situations when the liver function is grossly deranged or there is a significant coagulation abnormality, your prothrombin time, nearly no clot, and platelets are just 30, 40,000, and our patient is already on some anticoagulant therapy, maybe oral anticoagulant. So in those conditions, anticoagulation should be avoided. You can use a saline flush, or like in the Prismaflex, at the pre-blood pump position, you can always dilute it with using the normal saline, so that you can dilute the blood so fetal life can be increased. Though there is a limited data, but they should be used only when the patient's anticoagulation is contraindicated. How we can improve the filter life, because this is a big concern when we are managing a patient on CRRT, because it adds on the cost. The moment you change the filter, cost becomes double. So anything which leads to reduction in the stasis of flow should be avoided. So alarms should be respected and alarms should be responded very quickly, so that your blood pump is not stopping very frequently or not stopping for a long time. Your vascular access should be very good, because if there is too much of negative pressure in the vascular access, it will induce a lot of vacuolization and clotting. The staff should be trained to handle this situation. They respond very quickly to this. And then how the therapy should be optimized, your filtration versus dialysis. Sorry. So filtration, when you are doing a very high filtration, then there is more chances of clotting of the circuit. So pre and post dilution should be adjusted. Your filtration fraction should be less than 25, and air blood contact, any air bubble in the circuit should be very quickly removed, or you should ensure that your circuit priming is very good, and this is how you can improve the filter life. So we all know that the CRT has a certain advantage of the patients who are hemodynamically unstable, that probably may help for the better renal recovery. It has a stable and predictable volume control, because you are controlling all pumps. And in fact, on the long run, probably you can have a better removal of the fluid from the patient. And moreover, it will give a stable and predictable control of the blood chemistry, intracranial pressure, again, which is a concern. CRRT is indicated as per the KDIGO guidelines, and possibly helping for with cytokine removal. Possibly it can have certain help with the sepsis patient. But the disadvantage, you need to have anticoagulation, so that will lead to increased bleeding risk. High heparin exposure can lead to a heparin-induced thrombocytopenia. There is a higher potential for filter clotting, and it is definitely expensive, because you are using a lot of fluids, replacement fluid, or you are using citrate, and for a long time you are immobilizing your patient, or if patient needs certain investigation, transportation may be an issue. So to conclude my talk, the basic principle of CRRT is not different in basics with any kind of a therapy which we provide, whether it's an intermittent hemodialysis or SLED or CRRT. So basic principle is the diffusion, which we use for the hemodialysis. Along with that, we add convection, so we are doing a hemofiltration, and when we combine it, it's a hemodiafiltration. As adsorption, which is an additional advantage with the help of CRRT, which probably may not have we do not have a scientific evidence to prove it that it's definitely beneficial. However, we should remember that the diffusion remove only the small molecules, while convection removes both small and middle molecule. A good vascular access will help you to run your therapy and prevent a premature clotting of the filter. Heparin is most commonly used. However, the regional citrate anticoagulation is gaining popularity, but we should remember that there is a strict protocol and it's a pretty costlier therapy when we are running CRRT. And how we are going to select the modality and dose of the therapy, it has to be individualized, which will be discussed in the subsequent lecture. The selection of buffering agent again will depend upon the patient clinical condition. Ensure that the hepatic dysfunction patient avoid your lactate-based solution. However, in other cases, you can freely use the lactate-based solution, which are cheaper and more stable solution. The replacement solution may be administered as a pre and post dilution, but you should be aware, you should know that what exactly you want. If you want to avoid filter clotting, pre-dilution is a better option. If you want a better solid control management, then it's a post dilution. The clearance of solid depends upon the different factors, including the molecular size, pore size, and the sieving coefficient. Thank you very much. If you have any question, and sir, if you have any comment.
Thank you, Dr. Vivek, for that excellent presentation and introduction to the technique of renal replacement therapy. And I congratulate you for such a nice lecture. As before moving on to the next topic, I just want to comment that yes, to our delegates and to all of us, that the essence of renal replacement, the success of renal replacement lies on putting a good catheter. And here you are taking blood from the same vein, filtering it and pushing back into the same vein. So that catheter is very important. Best is the left internal jugular, as he has already, right internal jugular, as Dr. Vivek has told, followed by the femoral. And if you are putting the vein catheter in the femoral, at least put it for 20 centimeters to prevent recirculation inside the catheter. Yes, human kidneys act convectively, so ultrafiltration and convection may be more physiological. But as Dr. Vivek said, that in critically ill patients, it's very difficult to compare different type of modalities and to prove the superiority of one or another. It is not important to prove the superiority, but it is the convenience in which a patient is saved, whether it is by CRRT or SLATE or hemodialysis. So I don't find any question here in the chat. Lopa, do you find any questions out here?
Yes, I think there is a
one question is there, I suppose, from Mohammed Badawi, and he has asked, what about the exchange rate? How to calculate it and adjust according to different cases?
Sir, what is the question?
The question is, what about the exchange rate? How to calculate it and adjust according to different cases?
So I think you are going to take this talk about the how to calculate it and what. That's why I have left this component.
Yes. So in the doses part, we will try to discuss on this, and if something is left, that will be discussed during the discussion.